You're listening to a Raconteur Studios podcast.
Welcome to the After Hours Skin Clinic. I'm Dr Emma Craythorne, a consultant dermatologist and your host. And today I'm really excited because I'm joined by Dr Sigi Joseph. Sigi is a specialist in women's health. We have so much to share with you, whether it's periods or perimenopause or the gender health gap. There's lots to talk about. Women's health is something that affects half the population every single day. Yet there are so many aspects of it that just really don't get talked about. From menstrual cycles and perimenopause to postmenopause and real gendered health inequalities, women are often left navigating some complex changes, and sometimes they don't really have much guidance or support. But here's the thing, a woman will have a period every month for about 40 years of her life. And yet this is still an area that really is seen sometimes as a bit of a taboo. A recent survey today showed a quarter of women actually felt some shame when they were trying to seek out help for very heavy periods that they were having. So today I'm joined by someone who is an absolute force in women's health, the brilliant Dr Sigi Joseph.
Hello, Emma.
So I just want to set the scene because I first met Sigi at medical school, and from the moment we crossed paths, it was really clear that she really truly is an absolute powerhouse. She's this real way of bringing everyone together. She always has the biggest smile on her face. She's the warmest heart and a real desire to make a difference. But beyond that, Sigi is honestly one of the solidest friendships you could ever hope for. She's someone who collects and cherishes bonds with people more than actually anyone I've ever met. And she has this really incredible open door policy. We first met at medical school. Our paths collided and we stayed together the entire way through medical school, even living together. We studied together and we got through all of our finals together. And in fact, we were so deep in revision that we somehow managed to convince ourselves that if we changed out of the sweatshirts that we were wearing, then all of the knowledge that we'd managed to cram in over those months before taking the final would somehow disappear. And so, complete with tomato pasta, raita that Sigi's mum had made for us, we then did our medical finals and passed them with glowing colours.
I wondered if that story would come up.
And so the reason why Sigi is here today is because that real desire to make a difference has continued on through her medical career. She is a GP, and anybody who falls into the catchment area where Sigi is their GP is a very, very lucky person indeed. But she is a real specialist in women's health, and she spends every day helping women understand their bodies, spreading knowledge and information throughout communities, and really is making a massive difference in terms of policy setting within our healthcare system. So Sigi and I are going to delve deep into issues affecting women's health and the gender inequality that sometimes happens. Welcome, Sigi.
Hello, hi, thanks Emma for that glowing report.
Do you remember those days?
Yes. And I remember seeing you across the room and thinking, I need to be friends with that girl. And that was, I think, our second day at university. And I was lucky that you and I became friends then. And we've had so many adventures over the years and really supported each other, I think, and pushed each other on and shared ideas. And it's been wonderful. I'm so lucky.
And it also feels quite nice that we're talking about all of these issues that happen to women because we really met whenever we were girls.
Yes.
And you're at medical school. But now as time has gone past and many years, we've become women and doctors and mothers.
Yeah.
And many of the stages of things that we're going to talk about now, we just talk about in our spare time. In fact, we talked about on the way to the studio today, didn't we?
Yes, absolutely. And I think the way that I would explain this is what happens in Scotland. You say, why does that happen like that? And I think, I don't know. I'm going to go and speak to the politicians about that. And we kind of drive each other on over the years to make change for the population. So it's been brilliant.
So can you tell us a little bit about all of the things that you're doing for women's health? Because I know, but I want everybody who's listening to this podcast to understand what's happening in your world and how you're making this difference in women's health.
So I'm a GP and I've got a practice with about 6,500 patients. I've been there for a long, long time. So I serve all of their needs for all healthcare. And Alongside of that, I've seen disparities in the way that women are receiving healthcare or access to medicines, for example, or investigations. And I have several jobs out with my practice. So I've been teaching for 20 years. I've taught over 1,000 doctors locally in Edinburgh. And then separately to that, the Royal College asked me to work alongside them. And some of the work I do with them is around actual GP workforce retention and burnout. But a lot of what I moved into is women's health. And that led to policy, that led to some news appearances, and then that's also led to creating, educational resources for every primary care clinician in Scotland and things like that. So it's really grown, and partly driven by thinking, well, why does that happen and why can't we access better healthcare for our patient, and really get all the clinicians understanding what's going on and changing policy, changing access to things. So it's really just grown over the years.
Yeah, because I was at a meeting the other day and Dame Leslie Regan was at the meeting, who I know that you really respect. Yeah. She made the comment, and I hadn't actually thought of this because it always forms part of my history taking whenever I'm seeing a patient who's presenting with anything. Are you still having your periods, and do your periods bother you? But she said that actually that question is often not asked, and a whole consultation could go by, even investigating things like tummy pain, but yet it's not asked, do you have a period?
And that is absolutely correct. So what I didn't say is I was the clinical representative on writing Scotland's Women's Health Plan, and you've got the Women's Health Strategy in England, of which Leslie Regan is the head of that, and we've got our own head, Professor Anna Glazier. So we wrote that over 3 or 4 years, and we're really deep diving into, women are getting almost like siloed care. So they might see a cardiologist because they've got palpitations, but nobody asks them about perimenopause. And likewise, endocrine specialists might see them, but actually the stage of their period cycle is incredibly important to a lot of endocrine symptoms. So quite a lot of the first phase work was thinking, how do we get this question with every time a woman or a young girl sees a clinician, whether that's a specialist nurse, pharmacist or doctor, are they thinking, have hormones got a part to play here? Where are they in their life cycle? So we're really thinking about the life cycle of a girl from, our youngest at age 7 right up to the postmenopausal years and that good health that we want for those women. So she's absolutely right. I think women repeatedly will see healthcare workers maybe even get some investigations done without that being considered. So hopefully we're making steps to change that now.
So is it much of a problem then where you've got young girls, I'm thinking of young girls just started their period or maybe 5 years into having their period, and that might be pretty irregular for them or painful for them or uncomfortable for them. And do you think that they just don't talk about it? Do you think they won't mention it to their parents or a doctor?
Yes, it's multifactorial. I think there's maybe a lack of understanding of what is a normal period and what can be acceptable within that 4 to 5 weekly cycle that the young girl's experiencing. Remember, it's new for her. There's a lot around what's her relationship like with her parents, cultural implications, speaking to friends and what the conversations are. And then there's understanding that actually a period should not be so painful that you can't go to school, you can't go to work, that you're needing to take painkillers for big parts of that cycle. It shouldn't be so heavy that you have to change your period products every hour and, you're flooding the bed, you're having real difficulty there. So first of all, it's having the population understand what is normal and what's not. And the study you mentioned from the Wellbeing of Women actually just came out, and they had surveyed 3,000 women. They had found out of those 3,000 women, actually, and it takes an average of 2 years for someone to come forward with heavy menstrual bleeding, because they're thinking, well, this is normal for me, maybe I shouldn't do anything about it. Or they're just maybe even having access trouble trying to get to the clinician because the GP surgeries are extremely pressured. And
2 years when you think about it, so 2 years of abnormal bleeding.
Yes.
That's 24 times.
Yes.
That is a lot.
It really is a lot. And then the women themselves could be anemic as a result. They can be breathless. They could have faints that could lead to injuries. There's a lot of things that are the fallout of these really heavy periods. And there's a lot of conditions. If you're having heavy menstrual bleeding because of, for example, fibroids, which are growths in the uterus, or endometriosis, which is where the womb lining is actually out with just the womb and it's in different parts of the cavities within your abdomen and maybe even on your bladder or your bowel, it can cause painful heavy periods. Once we know what the cause is, there's often treatments there that we can put in place. So I guess if you've got difficult symptoms with your periods, it's first of all doing a bit of mapping, trying to understand what is the routine, what's the pattern with this. The period tracker that was just launched from Wellbeing of Women is really, really good.
I'm just thinking about the person who might be listening to this and they're thinking, oh my gosh, I actually have really heavy periods.
Yeah.
Like, what do I do that? So your idea is that you make a map of this and you keep a diary?
Yes, I think first of all, it's really useful even if you have, in inverted commas, plumb normal periods. So for example, our young teenage daughters, it's really good for them just to start tracking. When am I expecting my period? Is that why I feel a bit more grumpy? Is that why I'm feeling more sluggish? And they know to expect that.
And there's so many apps.
Yeah, there's lots of brilliant apps out there, and have that understanding of their own bodies. I think it's something I repeatedly say, and particularly around perimenopause as well. Have that understanding of your own body and what to expect. And then when you're experiencing your period, it's, having a look at days of bleeding. How heavy is the bleeding? Are you needing to change products very, very frequently? And it's really hard because if you look at, blood on a period product or down the toilet, it can look like a huge amount. So it's trying to get an understanding of your own body and what's normal for you.
What would be a heavy period?
So there are some guidelines, but I don't know how you would actually practically tell a girl to measure exactly the volume of that. But anything from 160 to 170 mils of fluid, and losing more than that would be considered heavy bleeding.
Over the whole period?
Over your period. So that one cycle, it is difficult to quantify, but I would also go on, I've just changed my tampon or I've just changed my pad and then it's already soaked through within an hour to 2 hours. That's not normal. And I would definitely say track this, but more importantly, speak to someone about it. Because if you think about even the fittest and healthiest of bodies, if they're having heavy bleeding every month, you're losing your iron, you're losing your energy. I had a patient recently who was getting lots and lots of viral colds and infections and wondered why. We've actually realised, she's got very heavy periods and we're replacing the iron and slowing down the flow of her periods with medicines, and it's made a big difference.
So instead of actually trying to measure it in mils or teacups or whatever, you can get these cups that you can essentially pop inside the vagina, just at the opening of the cervix.
Yes.
And then it'll collect your period blood. So more practically.
They're very popular. It's just they weren't around when we were younger. Yeah. But yes, I see more and more people talking about using these cups to control. Moon cups, yeah.
So if you weren't using those, I suppose a practical way of thinking is that if you're changing your tampon or your pad more frequently than
very frequently. So let's say every 1 to 2 hours, that would be very heavy. You should be able to put a pad on. For example, a schoolgirl should be able to put it on before school starts and change it at mid-morning break or lunchtime. Yeah. So if that's not happening, or you're flooding through clothing or your bed sheets, then this is not normal and you should definitely speak to someone. There's often a root cause that we can then manage.
Okay, so you're mapping out your period. That's obviously to see whether they're regular or not and see how long they last.
Yes.
And then you map them out to see how heavy they are. Are there other kind of symptoms that are important either before or during or after a period that people might want to think about?
Definitely. So I think almost all women will experience changes within that period cycle, and they should be manageable and minimal. So some women will get a lot of bloating, maybe some breast pain in that premenstrual days. But you've got symptoms, things like more severe PMS, which might be mood related, and there's a further condition which is premenstrual dysphoric disorder, which is very, very serious, and it's causing your mood to be so low, either just before your period and into that period, that you're thinking about self-harm. You can't leave the house. These are happening to women out there.
It's very extreme.
Well, premenstrual syndrome that's a bit more severe is fairly common, but PMDD is basically a more severe form of PMS syndrome, and patients that I've come across can have really difficult mental health changes to the point that they're feeling suicidal with their periods. And it's really important healthcare clinicians take it seriously, recognise it, and really help support that woman to get the care that they need. So it would probably be maybe in the 1.5% to 2% range of the population would have PMDD.
I mean, that's a lot of people. That is a lot of people.
It's a lot of people in the country, and also PMS can be very impactful on a patient's life. So if you imagine, you can all experience maybe a bit of low mood anxiety before we start our periods, particularly as our progesterone's tailing off. Progesterone is a bit of an anti-anxiety hormone. It can help us get a good sleep.
I love progesterone. That's my favourite hormone.
Yeah.
Whenever I was pregnant, I was like, sign me up for anything. I'm like, no anxiety whatsoever.
There's hormones that can be really beneficial. So mid-cycle, our estrogen's really high. And often that's almost like your superwoman hormone. You're feeling really confident, your hair looks good. And our bodies are clever. Our estrogen's rising because they want us to catch that egg and make that egg fertile. So they're wanting you to feel like having sex and becoming pregnant. As the estrogen's tailing down, our progesterone actually has a surge. So still, we can have that anti-anxiety effect. Our sleep can be good. But pre-menstrually, so before we start bleeding, both of those hormones are flattening off. And that's where you can get bloating, you can get oily skin changes, acne, constipation. You can feel really tearful or irritable and quite low. And PMDD that you mentioned is a more extreme form of that. I will see patients who are struggling on with that. When we talked earlier about stigma and not wanting to kind of share that you're feeling suicidal every month, or, and not really knowing where to turn, and maybe even almost gaslighting yourself and thinking, well, it'll be better next month. I'm not going to get help. I'll be fine.
Or even just not recognising it at all and not realising that the two things are linked.
Yes.
And then you're a pretty rubbish person at work that day, or you get into a fight, or you've got your A-levels or GCSEs to do, and it happens to fall at this point of your period where it's going to potentially negatively impact your scores.
Yeah, I think that's, when I'm speaking to teenagers that are coming to see me, I'm saying, like, this is so important, this part of your school career. Let's try and sort out these hormones so that you can, even if it's just for the 6 months when you're sitting your prelims and then your exams, so that you're not having those monthly peaks and troughs that are really affecting you. But the treatment would be with hormones, so some form of contraception for that age group. So it's not for everyone, but it's trying to break down that stigma, that taboo about talking about periods. Even normal periods do have symptoms with it, as we mentioned: constipation, bloating, tiredness, skin changes. So, we need understanding from our friends, from our family, from our partners. And then it's when it's more extreme and a woman's suffering with more significant symptoms, and then possibly we're having diagnoses missed, like endometriosis or fibroids or something else that needs more medical management.
And so what are the kind of treatments and the kind of things that can happen if somebody does have very heavy periods, painful periods, or does have PMDD or severe symptoms of PMS?
So first of all, it's having that conversation, maybe thinking about, does this fall out of range for normal, either mapping it and thinking about it. If I saw a patient that I thought, this is sounding particularly heavy, I would usually run some blood tests, certainly for a full blood count, check their iron levels, and also their thyroid, because sometimes thyroid dysfunction can cause kind of abnormal bleeding. And then we're starting to think, okay, what are the causes here? And that's where we run into problems, particularly on the NHS, and in that we might do an ultrasound, but that ultrasound now is taking longer and longer. For things like endometriosis, the diagnosis is on laparoscopy, which is a camera through the belly button. That needs to be done by a specialist. And we know that waiting times are exponentially higher than other specialties in gynecology. That's complex as to why that's happened, but it's partly post-COVID as well. So it's first of all getting the diagnosis. But for me, for example, the lady I was talking about who's had presented with just a series of horrible viral illnesses, saying, I'm just so run down. So as part of that, you might meet a clinician that wouldn't say, well, what are your periods like? But, she's actually works as a nurse. She's really, really busy. She's got young children. I said, what are your periods like? Actually, they're really, really heavy. They've been like this for a long time. So what I've done while I'm waiting for her ultrasound is I can manage her periods. She didn't want hormones. So we talked about, there's something called tranexamic acid that works on the uterine arteries. It's an anti-inflammatory tablet. It can reduce the amount of period bleeding
I
that you
use that
have.
for melasma.
Yes. Okay.
In dermatology.
That's interesting. Yeah, that's interesting. So for her, we were saying, well, let's try and slow the bleeding if you don't want hormones, and give her some iron. So I've replaced her iron, and we'll repeat her blood tests after her iron treatment. But if she did want hormonal management, then there's things like, basically, most of the straightforward options are looking at contraceptive pills. So either the combined pill or the progesterone-only pill, the implants, injections, or even the coil. But you've got to take each individual person's risk and what their wishes are and their thoughts are around that. With PMDD, we might often work through various options for treating that within general practice. But a lot of these ladies, if we're really struggling, might end up with a specialist. And so I would see some of these patients, but in general practice up and down the country, you might be asked to see a gynae specialist or a menopause specialist even might manage this. And there are clever things you can do that can switch down basically ovarian function. So there's these things called GnRH injections that we can use and different analogues that we can use to try and control that period cycle. So there's lots of clever hormonal medicines we can use.
But it all starts with recognising that what is normal and what is not normal.
Yeah.
And speaking to a healthcare professional, your GP, parents perhaps, so that you can actually start on that journey.
I think that's it. And a lot of things that I've been kind of working on for a number of years is just that patient engagement. Just let the population know this isn't normal, what's happening. And having that stigma reduced so we can talk about it. We've been doing great things in Scotland. I can't speak for England, but we've been working with the schools. We're changing the education packages for primary 7 girls and boys. We're bringing menopause, the word menopause, into teenage girls at school, which is really positive. And that's been part of the Women's Health Plan. So that's going to take time to filter through, but it's breaking that taboo about talking about what's normal, not normal. And that's where things like these period trackers, symptom trackers can be really useful. But also when you meet a clinician, my biggest ask would be that when I have my trainees that I've been training for years and years, I'll say, look, we need to know an awful lot of medicine about an awful lot of things, but you can do a good consultation. Even if you don't know exactly what the condition is, you can be empathic. You can really listen to the quality of life impacts, what's happening for this patient. And then you can take it further, either by speaking to colleagues or doing a bit of reading and understanding. So I would really hope when a woman or a young girl comes and speaks to any healthcare professional about their periods, that they're met with that kind of empathy, that understanding, and taking the time to really think, what can I do for this lady? And even if you don't, as the clinician, have that direct answer, take the time to find it or speak to a colleague.
But it's often with these taboo subjects, isn't it, that they just do go, like having a period is clearly not a taboo subject, but it's almost as taboo as having a poo. People don't really talk about it.
They don't,
But actually talking about these things is probably one of the most important things that we can do, really.
Yeah, and I've really seen, I think that is changing. And I think young girls, I'm so impressed with my teenage daughter. She's so empowered to come home and just say, I was learning about this today, and using vulva for the anatomy and being really confident to talk about bleeding, and her brother might be there, or, Mum, what happens here? And my 7-year-old daughter's asking, what's this? And so hopefully the generation behind us will be working hard to break that down.
We should buy our own tampons in the shop.
I don't know about that, but no.
My girls don't. I actually still send my husband to buy mine, to be fair.
He just does lots of your chores for you.
PCOS is another condition very much related to hormonal changes in a woman as well. And it's pretty common. I mean, there's probably around about 10 to 13% of the population of women that might have this. And around 70% of them remain completely undiagnosed. With PCOS, you've got a change in the hormonal profile. And what happens is, as a dermatologist, we typically see somebody who has acne that is often cyclical, but not all the time. They always have oily skin or seborrhea. So that's our technical term for oily skin. Quite often we'll have an oily scalp and dandruff. They're real keys for me. And often we'll have hair in areas that they don't want to have hair. So perhaps on the chin or the chest, the beard area. And sometimes the hair is much thinner, particularly at the sides of the temples. And it's typically because of having too much insulin in the body. So this hyperinsulinemia.
And also, along with that, is those other impacts. So there's the mental health impacts of having the excess hair in places you don't want, and the weight. So often they really struggle to keep their weight down, which can then link to cardiovascular risks or diabetic risks as well. So really important to pick it up.
And a key thing for picking it up is actually going back to what we talked about at the beginning.
Yes.
The irregular periods, maybe not even having a period, or having a period that's really, really, really heavy. So with this one condition, polycystic ovarian syndrome, even within that condition, there's not a normal way to have a period, because some people don't have any. Some people have really heavy periods that are painful, and others have very, very erratic periods not presenting all of the time.
Yeah, so it goes back to that, what we were talking about at the beginning, recognise what's normal for you and track that, and maybe bring that to somebody, whether it's a family member, and speak to a clinician, because we want to pick these conditions up early and try and again manage them.
Especially with PCOS, this is a condition that, yes, we're picking it up because often somebody might think they just have acne or some hair growing in funny places that they don't want to. But I think what you say, it's the metabolic side of it. So the high cholesterol,
the diabetic risk, and the heart health. So we've got to really think, again, a lot of what I do and you do is think about the person as a whole.
So let's talk now about those perimenopausal years. I loved it whenever we did a panel together, and you have to picture the scene. It was a wonderful panel. It had sleep experts, nutritional experts. I was there as the dermatologist and Sigi was there as the women's health expert. And it was all about menopause and the premenopausal time. And Sigi came out with an amazing statement that just said, menopause is a single day. That's it. It's a single day in a woman's life. But actually what we're all talking about whenever it comes to all of the symptoms is this perimenopausal time, or really premenopausal time, so the time in the run-up to that single day in a woman's life. And that can be for around about 10 years with lots of very mixed symptoms. So some people with flushing, some people with brain fog, some people with, which is at least the area that I can talk confidently on, skin changes. Let's talk about that.
Yeah, so you've obviously been listening, Emma. That's brilliant. But, and that's it. So a lot of what we see in the news and the media and we're talking about is that optimising health in the peri and, like you say, pre-menopause. So menopause very specifically speaks about one day, 12 months after your last menstrual period. Everything before that is pre and perimenopause, and everything after that is postmenopause. And like I said, if we're lucky enough to live long enough, we could have a third of our lives in postmenopause. But what we know in that perimenopausal stage is a lot of physiological changes are happening in our body. And it's really important to make our health really, really good. There's a lot of skin changes, more rapid aging in that time, but also things that we don't see around cholesterol, the way that fat lays down in our body, our bone strength. So that's the difference really when we're talking about it, and maximising that health on the run up to that menopause is really important.
Yeah, because I think about it from a skin perspective. So we know in the perimenopausal period that we're getting this decline in collagen. And it's really evident because you do see that is whenever you're starting to get more of your lines and more of your wrinkles appearing. And then in that postmenopausal time, you've got this huge drop in your collagen levels. And that's why some people will often say they've aged very quickly or aged overnight. Now, it's not, that's an exaggeration, but you do get this impression within a couple of years the skin does age quickly. But the same thing happens in the skin, that you get this change in the skin barrier. So your skin becomes drier, you get more susceptible to irritations in the environment. And some people develop kind of rashes and dermatitis, eczema for the first time. So I see all of these things in the skin, and everyone else can see these things in the skin because they're looking at the skin from the outside. But you told me some interesting things that happen with the heart, which always struck with me. Yeah. And you call this the window of opportunity, which I love, particularly for bone health.
So that's it. So there's the things that we can see, and even acne actually is another common skin change with the hormones changing. But the thing that we don't talk about or we aren't really aware of is what's happening to our bone structure. So the little osteoclasts in our body are actually firing up and they're working harder to break down our bones.
An osteoclast is a cell that eats bone.
And it's basically rapidly speeding up, eating down that bone, making them less strong, and that's adding to the osteoporosis issues later in life. We've got changes in the way that even things like our cholesterol are metabolized, so that can put our heart health risk up. Our blood pressure can change as well as a result of some of the changes to do with the estrogen function. So without getting too technical, there's cardiovascular risks that are going up that we can't see. There's the ones that we can see as well. Our bodies are clever and it starts to try and hang on to fat, particularly around the midline. And so that's when clever. Patients talk about this muffin top or have suddenly become big around the middle. Our bodies are trying to say, well, adipose tissue, so fat cells, have an ability to produce some estrogen in a way. There's a more clever process than
so that's why.
Yeah, so the body is trying to say, well, hang on to this so we can try and get some more estrogen for this woman. So often, again, if we're getting that central obesity, we know that directly makes our heart health poorer. So these are just some of the impacts and facts, even if you don't think about anxiety and loss of confidence at work and the financial implications of that as well.
Because I think that is one really important factor about heart health. What is the difference between men and women in terms of their cardiovascular health then over time?
So I think that's a brilliant question. So I think we've got a good awareness with our male populations around cardiovascular health. And what we know is a man's cardiovascular risks will gradually increase over time. But for women, they can actually go along, if we imagine a graph, they can go along a bit lower with cardiovascular risk. But by the time they're hitting menopause, there's actually a steep incline in our cardiovascular risk, and we're almost matching up to men's cardiovascular risk. Obviously, certain things will put you at higher risk. So family history, smoking, high cholesterol diet, lack of activity. But we do see that women who might traditionally have a lower risk in that perimenopause, their risk can almost catch up.
And then potentially going back to this idea of this gap between genders, maybe women aren't thinking about their cardiovascular risk, whereas men slightly have it drilled into them and there is more of an awareness. But I think women don't necessarily have the same worry about their cardiovascular health. I think healthcare professionals also fall guilty of perhaps thinking that as well.
Yeah, I couldn't agree more. So things like palpitations, chest pain, you're just a bit anxious, maybe being almost gaslit again, maybe either by family members or healthcare professionals even, and understanding that our risks are rapidly increasing and just we want to make ourselves well from that point of view. The other thing we didn't mention is when you're feeling really low or very anxious, often our dietary habits change and we eat poorly and we do less activity, which again contributes to that heart health.
And poor sleep, because of course in the perimenopausal time there's that sleep disruption, which then the next day causes more stress because you haven't slept properly, which then feeds into poor choices over food, poor choices over alcohol. I think there's probably a lot of self-medication of alcohol in that perimenopausal time, which feeds further into poor sleep. And then that has an impact on the job that you do. You will see this because this is really your area, but there must be people who feel like they can't cope with their jobs. And men don't have that because they're not going through this cyclical change.
Yeah, absolutely. I think the statistics are there's around 1 in 10 women consider leaving their jobs in that perimenopausal time. And it really is important. And a lot of what we're doing with policy and trying to talk about workplace culture, you don't want to lose these extremely experienced staff members at that stage of their career. So we should be having that open conversation again, reducing stigma to try and make sure that the person feels comfortable to ask for maybe workplace adjustments. They talk about micro adjustments that can be even just really beneficial, like changing the time that a woman can get a toilet break because they might need to go more frequently, and maybe uniforms and looking at the uniform material. I know they talk about that in the NHS. They've been looking at the uniforms.
I didn't know that.
So it's not necessarily that these perimenopausal women need drastic changes to workplace. Often micro adjustments can be really effective. But what we want is the people out there to know actually perimenopause can be managed really well when you speak to somebody. And for those that can take HRT, that's really beneficial. And if you can't, there's still lifestyle adjustments, CBT, there's things that we can do. So not to suffer in silence and really think about that. The statistic, 1 in 10 women at that age thinking about leaving work has huge economical impacts as well.
I noticed that nothing of what you said revolved around the use of supplements or pillows or sheets or shampoos that have the word menopause written on them. Why did you not mention any of those things, Dr. Sigi Joseph?
Well, I think a bit like probably your field of specialty, skin, there's a lot of misinformation or disinformation out there. So really when I don't talk about supplements, there's little evidence, and that might be partly that there's not a lot of evidence generally around them, but also things like vitamin D, absolutely. We know that that's a given, especially living in Scotland. But really a lot of these things around T-shirts, I've seen T-shirts advertised, jogging bottoms, types of tea. It's not biochemically and hormonally going to correct things, but perhaps it makes the woman feel a bit better, which in turn can help with anxiety or, but I certainly don't with my patient clinically recommend things, and I really don't want people spending money they don't have on things that haven't got the randomised control evidence that we talk about, in our scientific world.
Yeah, so if you're depleting something or if you're not eating the right amount of something, so I will always say to my patients, if they're not eating enough oily fish 3 times a week, well then supplement with omega-3. Everybody probably just needs to supplement with vitamin D because we live in a country that appears to have zero sun or even light or blue skies anymore. So that supplementation with vitamin D is pretty essential for that immune function. But other than that, unless you're deplete, it's really difficult to say that a supplement is going to be of any benefit. And actually, as we're seeing, there can be of actual harm.
Yeah. And I think especially if they're in place of seeking good medical help, which might be HRT, which would prevent some of those chronic conditions we're talking about bone health and heart health. So it's having that informed discussion and not being kind of missold things and trying things that maybe you can't afford or that haven't got enough evidence. And always that food first, when we did our panel in nutrition, I was saying food first approach is better for all aspects of health.
Yeah, because, you might be thinking that you're in the perimenopausal time, but actually you've just got terrible high blood pressure. So getting that checked first. So in terms of harm from supplements, generally they're not going to cause much harm other than to your bank account, usually. But there are some supplements that can be bought online that are not regulated in quite the way that you might otherwise regulate a supplement within the UK, and they can just be bought and shipped in.
Yeah.
And many of the herbs are substitutes for things like steroids, for example, and they're the things that can then end up causing harm. Even with supplements that are bought within the UK, if used, they can sometimes interact with certain medications.
Yeah, absolutely. So that's really important. So some of our patients might have had breast cancer, for example, and now they're experiencing perimenopausal symptoms. They might buy some herbal medications that are not safe to actually use in patients on something called tamoxifen, which is a drug we might use with a breast cancer patient. Other drugs can interact with if you're on blood thinners. There's something called the herbal register, which if you are going to buy a herbal product, it's much better to do your research, make sure it's got that logo and speak to a herbalist. But again, I would go back to basics and say, let me speak to, a primary care team member or a specialist about what's right for me, particularly if you've got other medications or a breast cancer history or are on medication for breast cancer.
We do talk about this gender gap in the workplace, but I think everything that we've talked about is also this gender gap within healthcare as well. Mm-hmm. This real gender difference that we do see in health. And I don't mean that more women have breast cancer and more men have prostate cancer, because that's obviously a given. But what I mean is that for the same condition, men and women are often treated quite differently. Let's think about even something as simple as pain, for example.
Yeah.
So there was a study done looking at women and men going into A&E. They were given a pain chart to rate how much pain they were in. And the man was 50% more likely to be given pain relief than a woman, because the pain is dismissed more in women. And that study was not conducted that long ago. Do you see that in general practice?
Well, it's really difficult because we're all independently practicing, so I would never do that. And
of course you wouldn't.
But I do have patients that maybe would say they've been into a specialty and felt that way. But it's more when you look at the research papers, and I think 1 in 4 women feel that their pain has maybe been dismissed by a healthcare professional as opposed to 1 in 6. And it's thinking about why is that? And also I think women maybe dismiss their own symptoms. I'm just anxious, I'm just tired, I've got a headache because I'm a bit stressed, instead of I could have hypertension, so 51% of the population are women. We need equality of access to healthcare and really good access. The other thing is that there's less research with female patients and pregnant patients, and a lot less research in that field.
Well, I think it was until the 90s it was only men were allowed into the drug trials.
Yeah.
So everything was just tested on men's bodies. So a lot of those drugs were not actually tested on women's bodies. That's changed now, but even now that's changed. Most women still have to be in a form of contraception whenever they're on a drug trial. So again,
so the studies need to catch up with us, and we need more studies in the whole field of perimenopause and women's health. And I think there is some shift towards that, but it's a slow process, and it's having the people that fund the research prioritise that. There's actually a lot of studies around menopause in the workplace, and looking at the UK government report about the progress from shattering the silence about menopause. We can put it in the footnotes, but it talks about 14 million work days lost every year due to menopause, women needing to take off time due to symptoms, and also around half of those women actually increasing hours because of perceived loss of productivity. So is that because maybe within the workplace they're being judged, or they feel like they're not doing their job well? And that can be linked to anxiety or kind of feeling of dread or lack of sleep and anxiety. In addition, 20% of women say menopause has a negative effect on career progression. So if you extrapolate those figures, they say that actually it equates to about 1.8 billion GDP loss in the UK economy. But not just even thinking about finance, it's losing that experienced, skilled person out from your workplace. It's the relationship impacts. We know that divorce rates are highest at this age, relationships with your children and family. And so it's incredibly important to manage it well.
And from a human aspect, that is very compelling. But from a business finance aspect, then you think that we really should be doing better.
Yeah, and that's where I think a lot of the people that are advocating for change, I know in Scotland and England as well, and actually the Four Nations are saying, look, we're putting the money at the wrong point. Let's research this. Let's get healthcare out. Maybe incentivise clinicians to learn more about this, because particularly in general practice, we've got so much pressure on us and we've got so much to manage. We almost need to support the teams to then do the additional learning that might be needed. So it's that multifactorial thing in looking at school programmes and availability of medicines. But when you think about it, 1.8 billion from the GDP, it seems very sensible to me.
You would think then really that workplaces really want to almost instigate a menopause program.
Yeah.
I mean, really,
Yeah.
because you want to keep those staff members. You want them to feel supported. You might have to change things around a little bit, but you don't want to lose that woman who's in that menopausal time.
Yeah.
And, if I owned a big company, in the same way that you have your maternity leave to keep good members of staff, and when they come back, you want to have that same support for women who are experiencing perimenopausal symptoms. A bugbear of mine, and you know this, is acne.
Yeah.
Because I think that this idea of acne just being a single solitary term, and then there is guidelines that you have that are in general practice primary care that you must follow if someone presents with acne. And you and I both know that a 35-year-old woman presenting with acne needs a different treatment profile than a 17-year-old boy presenting with acne.
Yeah, it's no one size fits all. So what's the drivers for the acne? What's causing that? There's no point in just giving someone lots of antibiotics if the hormones are all in flux as well.
Yeah, I mean, I think that's right. Even things like your gold standard, we would use a treatment called benzoyl peroxide. Now, I like benzoyl peroxide as a wash. I think it's really great, but I think it's really great for teenagers with acne, boys and girls often, but for perimenopausal woman or a woman who has polycystic ovarian syndrome, which is a condition where there is a change in the hormones, which we'll also talk about, and acne is related to that hormonal drive, then things like benzoyl peroxide are actually just really irritating and they're not going to be helpful. Whereas hormonal control is going to be much more beneficial, and antibiotics, they'll deal with it for a very short period of time, but it's not going to be the treatment to adult female acne by any means. We're just seeing increasing numbers of women appearing in our clinics with acne in their 30s and 40s.
Yeah.
And then there's also the social stigma that's attached to that because, acne is a disease of kids, you think, that's a teenager gets acne, not somebody in their 40s, but there's increasing numbers that really do need help.
Yeah, I actually think I see far more acne in the 30, 40-year-olds than I do teenagers, actually, in my clinic.
It's almost then, I'm going to say normal, because it kind of is normal. It's such a common condition in teenagers, but it becomes not so prevalent in somebody in their 30s and 40s, but yet really, really problematic for them socially, problematic for them for their job. And there are increasing numbers of those patients coming through. So why do you think then that women are dismissed so often with their adult acne? Do you know? Why do you think that is?
Well, it's perhaps by the time they're seeing the doctor or nurse, they've got multiple symptoms, particularly if it's perimenopause. Maybe they've got lots of other symptoms that are needing addressed. They themselves maybe don't want to bring it up. I would like to think they're not necessarily being dismissed, but they're maybe the root cause or trying to balance out the hormones isn't part of maybe the treatment plan, which it would be a really sensible part of the treatment plan rather than just antibiotics or, like you say, washes that we use across the spectrum for teenagers and up the way. So it's partly what's available on formulary and maybe what the clinician's comfortable with and what they know.
Yeah, I think you need to change that, Sigs.
Yeah.
So I think the final thoughts are, and the messages that we want to give our mothers and our sisters and our daughters and our sons and husbands, the message is to talk about subjects like periods is a very good thing and a very normal thing to do, and sharing that information with people who you trust. because it is important to work out what is normal and what's not normal. And if you're suffering or having days where you're not able to go to work or go to your school, or it's interfering with the activities that you want to do, well, that would probably not be a normal period, would you say?
Yeah, absolutely. And register that and don't dismiss that for yourself, and go and speak to the right person.
And the same thing I then think holds true for a woman as they progress into this perimenopausal, menopausal period of life. We've only touched on some of the symptoms, but it's very different for every woman experiencing that perimenopausal time. And again, it is registering those symptoms. If you feel something, you genuinely feel it. You're not making it up. Yeah. You're feeling it. And then the next steps again is registering that.
Yeah, and just as you say, menopause is not a skin tight. It's very individual as to what they all experience. And so again, mapping it can help, and really registering it, and speak to trusted friends or family, and then speak to a healthcare professional. Absolutely.
And then I think even for clinicians listening and our colleagues, it's even very little things that I've learned from you is, asking somebody, are you having periods? Are they normal? Do they stop you doing the things that you want to do? Are they making you miss days from work? Just those simple questions can sometimes be so helpful when taking a history. And the same thing, I suppose, then holds true in that perimenopausal period as well. So that we're doing our best to not contribute to that gender health inequality gap.
Yeah, and like I say, if it's maybe you're not a women's health specialist, but you're a clinician, you can be empathic, you can take a good history, and you can go and look things up if you're not sure. Just always remember that if they've come to speak to you, it's usually because it's not going well. So let's listen to them and give them the help they need.
I've loved having you on this podcast. We've finally managed to get ourselves together in some kind of working capacity, which I've tried to for the last 25 years. Do you remember we tried to get our sister and brother to marry each other?
Yes,
and then we tried to pair off our own children to get together. You have to come back, because I think one thing that we didn't talk about was postmenopausal skin and vulval atrophy, which is a huge topic and a really, really important one. So let's do that the next time.
Fantastic. I look forward to it.
Thank you for joining us on the After Our Skin Clinic. As you can probably tell, there's a lot more to talk about on this subject, so I'll definitely be getting Sigi back. If you enjoyed this episode, then do subscribe or follow us. It really helps our numbers grow. Goodbye, lovely listeners. Take care of your skin, wear your SPF, and I'll see you next time on the After Our Skin Clinic. As always, this podcast is for informational purposes only and is not a substitute for medical advice. Please consult your healthcare professional before making a change to your treatment.